Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts. Welcome. Thank you for joining me for our AAOMPT podcast. I'm Rebecca Catlin, and I practice in Seattle, Washington. Today, we're excited to have our guest, Dr. Brian Dennison. He presented at our 2018 conference in Reno, Nevada on exercise prescription. Dr. Dennison is a private practice business owner in Mammoth Lakes, California. He completed his transitional DPT degree in 2007 at Regis University. In 2009, he completed his manual therapy fellowship training, also at Regis. He was fortunate to have a clinical faculty position at the University of Southern California early in his career, which included patient care at the university, faculty practice, and teaching assistant opportunities in the entry-level DPT program. His continued professional development provided teaching opportunities in the transitional DPT at Regis University, in addition to the residency and fellowship programs for evidence in motion. Currently, he holds an affiliate faculty position at Regis University, assisting in virtual rounds course of the Manual Therapy Fellowship Program. He has contributed 5 textbook chapters, an APTA cervical spine monograph, co-designed and taught a fellowship-level pain science course, and is currently a manuscript reviewer for the Journal of Manual Manipulative Therapy. He is interested in evidence-based patient management, incorporating the growing body of knowledge from the strength and conditioning field of research within a biopsychosocial model which appreciates pain sciences. Let's meet Dr. Brian and see what he has to say about his course. Brian, welcome to the American Academy podcast. Can you give us a little bit of background about the course you taught at the 2018 conference in Nevada?
Sure, no problem. Happy to be here and happy to discuss the course that we gave. It was a pre-conference course at the Academy meeting last year. And the title of our course was Therapeutic Exercise Prescription in Orthopedic Manual Therapy Practice, What Happens After Manual Therapy. And the presenters were myself, Dr. Michael Liao, and Dr. Brian Duncan. And the goal of our presentation was to try to share some of the excitement that the three of us have been having in our practice as we've been learning more about exercise prescription and the way that exercise can be used to complement what we're doing in clinical practice. But we wanted to make this presentation not just about taking patients and throwing weights at them or having them in the gym setting and just going all out with intense lifting. We wanted to frame it within a sound clinical reasoning framework. Especially, this is what we as PTs do when we evaluate our patients. We go through our evaluation process to determine what's the best treatment for our patients. And our goal was to try to identify a clinical reasoning process that PTs could use and incorporate exercise prescription into that. So we touch on some basic models of exercise prescription. We used the National Strength and Conditioning Association's model in our presentation. But we also talked about the clinical reasoning process, incorporating some of the growing body of knowledge in the pain sciences and trying to offer some strategies that therapists can use to identify what type of pain presentation a particular patient has, and then matching up an appropriate exercise prescription for that patient, incorporating some of the current knowledge from the strength and conditioning world and what they've been learning about exercise prescription and how to get people strong and how therapists could do that. So that kind of in a nutshell is what the general thrust or the general gist of our course was.
Okay, thank you. Can you elaborate a little bit on the prescription side of exercise? So that would assume that this is more clinically based and at a higher level of thought and process. You used a couple models. Can you delve into that just a little bit and explain how you're actually picking and choosing and using some of that clinical reasoning to prescribe?
Sure. So I think the process starts at the evaluation, and as you're evaluating the patient in the clinic, you're trying to get an appreciation for type of pain state for the patient that is in pain and presenting to your clinic. You're trying to get an appreciation for the type of pain state that they have. Is this a more normal type of pain presentation, or is it a more abnormal type of pain presentation? And as you gather your information from the clinical evaluation, that information can then be coupled with your impairment findings in terms of what you think might be contributors to that individual's pain state. Take the case of somebody with knee pain, and through the course of our evaluation, if we've determined that the predominant pain state that's present is a nociceptive pain state, then we can direct our exercise prescription towards the local tissue structures of the knee, and focus on exercises that will improve range of motion, and then also exercises that can stimulate muscle behavior and, in some cases, hopefully result in improvements in strength. Now, we contrast that with a patient that presents with a more centrally mediated pain state, and during the course of the evaluation, if we're picking up factors that seem to suggest that this patient's presentation is more centrally mediated, that doesn't mean that the patient's not appropriate for exercise. In fact, the literature would suggest that a patient like that should be exercised, and that's probably going to be a very favorable intervention for that patient. But we can't necessarily use the same type of prescriptive variables or programming variables that we would for somebody with a nociceptive pain state. And so we try to differentiate that in our presentation in the course that we did, where we tried to suggest programming models that would favor somebody with a nociceptive pain state versus a programming model which would favor somebody with a more centrally mediated pain state.
Okay, thank you for the deeper insight there. Your course also went into progression of exercise. If you're dealing with some newer therapists or folks that don't have as much background with treating patients under their belt, how do you go about giving them a baseline for when to progress and how to progress the exercises?
Sure, that's a great question, and I think your question is actually also part of what was encouraging us to look at doing this presentation. I think the three of us presenters feel that we have a tendency to underprescribe exercise, and the literature would tend to support that as well. The area of tendinopathy is one of the more noteworthy areas where load is a very important factor for treating patients, and so we wanted to demystify, for lack of a better word, the process of exercise prescription. And at times, exercise prescription can get very complex if you're looking at the collegiate levels or even the professional levels or elite athlete levels, where periodization models are being used. All 52 weeks of the year are mapped out in terms of what the individual is going to be doing. That's a very complex way of prescribing exercise with a specific goal in mind. And we wanted to acknowledge that there is that method of exercise prescription, but for us in the clinical setting, we can take advantage of that knowledge that has still been used for those populations that is growing. The NSCA is doing amazing work in terms of the knowledge in the strength and conditioning area, and we can still take from that body of knowledge and use it to even benefit our patients in the clinical setting. So we wanted to, again, demystify that process of exercise prescription doesn't have to necessarily be complex to be effective. But again, going back to that one of the contributors to why we wanted to do this course, I think that we can do better than what we're doing collectively as a profession. And so for those clinicians that may not have a background in program design, it's certainly been an area that I've been learning myself. Exercise prescription can still follow some of the basic tenets of what we've been taught in our entry level programs. What I'm going to assume most PTs have been taught in their entry level programs, and that's some basic loading principle with a set and repetition scheme of some kind being delivered to the patient. One of the most common scenarios is the 3 sets of 10, and I don't have a problem with 3 sets of 10 being utilized, but I think when we just leave our patients at 3 sets of 10 without any thought about intensity levels or a movement pattern or range of motion incorporated into that thought process, I think we're missing an opportunity to help our patients have better success. So certainly starting at that area, especially getting the patient comfortable with the exercise technique and getting them used to the idea of doing an activity for a certain number of sets and repetitions, and then thinking about their rest time, and then thinking about the intensity level. I think a PT could start at that area. And as the patient hopefully positively responds to that type of intervention, then the process can be encouraged, and you can start looking at changing up your repetition scheme, your rest times, your loading times, to try to target a more specific outcome for the therapeutic exercise prescription. In my practice, I tend to start patients with what I learned as what's called a neuroadaptation phase. I generally start my patients with a 2 week period of a generic kind of exercise prescription, 3 sets of 10, comfortable weight, comfortable rest time. And they go through that process. They get doing it pretty well on their own. And after that 2 week time period where they're comfortable with the machines, how to set the machines up, how to progress their load even at a low level, then we go ahead and I tend to end up targeting the strength program design variables with my patients after that point. My clinic has a large orthopedic population with a very active outdoor population that's eager to get back to doing the things that they want. And generally, I find they will benefit from a more strength prescribed exercise program. So that's kind of, and I think any clinician can do that once they know some of the basic variables of how to do that program design. And that was one of the things that we tried to get across in our course.
I'm glad you mentioned the 3 sets of 10 concept. That is super common, whether you're with a personal trainer or physical therapist. 3 sets of 10 is often standard. But what are you dosing for, and what are your clinical outcomes from that? Do you have any literature that comes to mind that speaks to how to dose and what sets and reps or percentage of one rep max you should be looking for either certain diagnoses or time frames within the rehab setting?
Yeah, that's a great question. So my original training that I got is specific to strength and conditioning, was based off of the NSCA's model. That's the National Strength and Conditioning Association's model. And my practice has been biased towards that. The American College of Sports Medicine also has a model of exercise prescription that you can find. We presented the NSCA model in our presentation. And that model will basically categorize your training goals into strength, power, hypertrophy, and endurance. And those are the basic 4 categories or training goals. And then there is a breakdown of the intensity or your load assignment that you'd be looking for if you're going to be targeting strength, if you're going to be targeting power, hypertrophy, or muscle endurance. And then the research from the strength and conditioning world has also set up sets and repetition schemes that will go along with that based on the research that they've done. And the ACSM has a similar model with the same type of exercise variable prescription for the intended target. So it goes back to that patient consultation where at the intake, you're starting to put together the patient presentation in terms of things that you might be helpful for that particular patient. And if it's something that you decide, I don't think my patient needs a hypertrophy program or an endurance program. I think they need a power program because they need to be able to go up 2 flights of stairs without having a limitation or being limited by that. And so I'm going to work on power versus hypertrophy or endurance or strength for that matter. And so you can prescribe the exercise plan that you have in mind for improving their capability to negotiate stairs with a power prescription, using the power variables to help you plan that and prescribe that.
Based on the organizations where you're getting some of your information, we're looking at probably a lot of that research is with healthy individuals. In physical therapy, we're dealing with people that are injured, and I'm thinking of more of the nociceptive tissue injury patient right now. How does that cause some differences in how you prescribe exercise, and maybe you have to vary from some of the models that you're looking at with strength and conditioning organizations?
Sure. I still use the same kind of template, for lack of a better word. If I'm looking at strength, I'm going to try to target 85% of that individual's 1 rep max, and usually I'm guesstimating that based on what they've done in that neural adaptation phase for the 2 week time period before we would go to a strength protocol. So I'd have the patient in my office. I give my patient a recording grid that has their machine, the exercise, the machine setup, the load that they're doing, sets, reps, and they record that. And my patients will actually go do that. I'm fortunate to have a clinic in a gym. So my patients will come and spend some of their skilled PT time with me, and then after they're done with me, they go out to do their gym program, and they record on their sheet at that time what they're doing for that in that neuroadaptation phase. After that 2 week period, we'll look over that recording grid, and then I'll go back and go work out with them again. I'll take one of our sessions where we go back into the gym, and I'll go through their exercise program with them, and I'll actually assign the load values that I believe will best reflect or best target that strength prescription. And one of the things that I've learned over the years that I've been doing this is that people will generally underestimate what they think that they can do. So it helps to have myself there or another PT that's skilled in exercise prescription to help the patient through that process. And going back to your question here, in terms of what do we do when we have a patient that may have a nociceptively dominated pain state, and the research is reflecting programming design that's for healthy individuals. And the template, I think, still applies, but modification may have to be needed. And that's where I think we as physical therapists have a kind of a unique aspect in exercise prescription. We can still take advantage of our strength and conditioning colleagues and the work that they're doing in their respective field. We can gain knowledge from that area and those professionals. But we as healthcare professionals specific to rehabilitation, we can use our understanding of tissue healing and any other type of situation that may play into the patient's rehabilitation or outcome. Psychosocial variables come to mind there. We can incorporate our idea or our understanding of these other contributing factors to a patient's state of well-being, along with their current pain state. For the sake of discussion, we'll say is nociceptive, and we can combine all of those variables that we are experts in, and then again, garnering the information from our strength and conditioning colleagues, we can combine those two together. So I don't think that the template changes from healthy individual to not healthy individual. And some of the research, especially in the tendinopathy area, is suggesting that we can take people with painful tendinopathies and load them up and make them lift heavy loads. And we find that when patients do that, they can have positive responses without negatively impacting their recovery process. And again, it goes back to that evaluation clinical reasoning process. What type of pain presentation does my patient have that can allow me to aggressively load my patient? And of course, in the state of tendinopathy, could say that there's a good chance that we could load our patient and have a successful outcome. For a patient that's recovering from a fracture, we may not be able to do those loading strategies early on in the recovery process. So early on in the recovery process, we may just do some isometric contractions, focus on range of motion where appropriate for the type of fracture that's present. And when the fracture has gone through the proper healing and has the clinical signs of an ongoing well healing process, then we can go ahead and start looking at integrating some of these concepts again from our strength and conditioning colleagues into our clinical practice. But we as the healthcare providers in these situations, physical therapists, have the expertise to be able to dose and prescribe exercise appropriate for the patient that's in front of us. And this is one of the points that I made in our presentation. One of the personal trainers, the club where my office is located, is a wonderful personal trainer. She's very skilled at what she does. She and I routinely discuss exercise concepts. Sometimes she'll have my patients as her clients that she's working with, and she's interested to know what things are safe for her to do and not safe for her to do with them. And she comes to discuss those things with me because she trusts my expertise as a physical therapist with all of those things that we just previously talked about as being helpful to help her be able to do her job. So in our area of physical therapy, we're not doing research like the strength and conditioning field is doing research. I've attended the NSCA conference for the past 3 years, and I'm blown away by the research that they're doing in the NSCA organization within the strength and conditioning field. We have that ability to be able to tap into that knowledge base with our area of expertise and make the treatment for our patients that much better.
Yeah, you just said a lot right there and some real important points relating to a little bit of the art of physical therapy and how to differentiate based on histology and tissue healing exactly what dose you need. And that's, a big part and core of physical therapy that might differentiate us from a Pilates class or even a personal trainer, like you mentioned, that you work with. And I definitely appreciate the information you're referring to coming out on evidence based strength and conditioning because I'm very much interested in the actual histology of what outcomes you get based on different dosages of exercise. And I've noticed in a lot of our literature, we'll have different experimental groups that are given a series of exercises. But my question is always, why were they given that? What's the efficacy of that particular exercise in that particular dose? Sometimes I think I would agree that's lacking in our literature. So whether the outcomes are good or not, I still am questioning why exactly were they given those exercises for this particular study.
Yeah, and I was just at the World Congress of Sports Physical Therapy up in Vancouver last week, and one of the presenters, Christian Barton, who's done a lot of work in the patellofemoral pain syndrome area, presented some information on exercise prescription for the treatment of patellofemoral pain. And this was a paper by Simon Lack, and I don't have a date on it, but the title is Proximal Muscle Rehabilitation is Effective for Patellofemoral Pain, a Systematic Review with Meta-Analyses. And what they looked at in this were studies that targeting patellofemoral pain with exercise and used term exercise or strength somewhere in their title. And they had 14 randomized controlled trials, and 13 of them had the word strength in the title. At an eye glance, you say, oh, it looks like this study is using a strength prescription for patients with patellofemoral pain. So out of those 14 RCTs, 13 of them used the word strength, one of them used the term neuromuscular. And then when they went through and analyzed those 14 studies, they compared the exercise prescription that was available in the RCT, and they matched the prescription up to what the American College of Sports Medicine says. If you imagine where I'm going with this, the actual studies that used a true strength programming design or strength protocol, out of those 14, 13 of them, again, remember, used that term strength. Only 3 of them actually used exercise prescription that would have reflected a strength programming design. 5 of them were endurance type of prescriptions. 4 of them were neuromuscular type of prescriptions. One of them was a power prescription, and the other one, they couldn't determine what it was. Even in our field where we're doing research and we're using exercise, we're not doing a very good job of defining what that exercise is in terms of a specific target. I think that kind of reflects what your interest is in looking at, okay, now, why did you use this particular type of dosing for this population in this paper? We're not matching up our exercise prescription to what is known out there in terms of effectively prescribing exercise. And in our presentation that we did last year, highlighted a study that looked at posterior tibial tendinopathy, and we looked at 3 different studies that had used exercise in order to, I think it was strengthen, if I'm remembering correctly. I might not be being fair here, but the 3 studies used a similar exercise. They wanted to use an exercise intervention in their design, and all 3 of them varied widely in terms of what they were prescribing. And I do think it was they were trying to do a strengthening protocol, but all 3 studies used quite a different prescribing method other than what is known out there. And I think that we can be better at what we're doing, and they've been talking about this since, I think it was 2006, one of the papers that we looked that was reporting on the variance in exercise parameters in research studies. And they've actually come out with some methods to actually prescribe research in a more consistent way, not only so that we can understand what the intent of the exercise prescription is, but then also so that we can reproduce this exercise prescription in clinical practice. And that's one of the things that we as clinicians, if we're not in the research world, we certainly want to be taking advantage of this growing knowledge out there. And when our research is being done and exercise is being prescribed and described in the article, we want to be able to take that information and be able to reproduce it in the clinical setting. If a research study comes out and says, hey, for this population of patients, this type of exercise worked real well. That's something that's going to catch my attention as a clinician, and I'm going to be interested in knowing what they did, and then how can I reproduce that in my clinic with the same type of population. And when the research is not reporting exercise in a way that we can then extrapolate from the research out into the clinical practice, that's a problem. And so I think that we can do a better job. There's definitely movements out there in the profession to try to improve how exercise is reported in the research. And hopefully this will be something that's embraced more broadly, especially as the amount of information that is coming out about the benefits of strength training, and not just having your patients do resistance training, but have them doing heavy resistance training. Last year, there was a paper looking at high intensity training for elderly adults after hip fracture, and they used heavy loading principles in that study with those patients, and the patients responded in a positive way. And so as this body of literature keeps growing, we want to be able to incorporate this into our clinical practice with our patients.
Absolutely. And you bring up, again, some real important points related to functional qualities that we're trying to train for. So if I look at an article, I may be interested in the exact exercises that they're doing,
Mm.
but they need to be consistent and intentional to report what quality they're looking for. Is it neuromuscle reeducation, endurance,
Mm-hmm.
strength, hypertrophy, or power?
Right.
Because that's certainly going to inform our ability to prescribe and dose and make it line up with evidence-based information that's out there.
Absolutely. I don't think you have one patient that comes into your practice and you just say, here's your one exercise prescription targeting strength. Some of my patients will start in that neuroadaptation phase, and then they may go to a strength phase because I'm interested in trying to get them as strong as they can be. I'm hypothesizing that if they have an increase in their base level of strength, that should help whatever impairments I've noted during the evaluation. And I'm thinking that strength can be the intervention to help out with that. But in my area, I have patients that go from summertime sport activities, leisure activities, to wintertime sporting and leisure activities. And so we may say in the fall season, here, let's have you do a program that's designed to try to beef up your baseline level of muscle strength. And then before we get into ski season, where you're going to need a little bit more endurance capacity of your muscles, we're going to switch your programming 2 months before ski season starts, and we'll emphasize an endurance program at that time. And this is with all things being considered that the patient is moving in a good direction. And then we'll change them to an endurance prescription to try to match up the demands of their activity that they're going to be doing. And then when they go into the spring, we'll say, okay, why don't we go back to a strength program? We'll try to get you build up some of your muscle strength again. And then hiking season and biking season comes around in the summertime, and we do the same type of thing where we say, in April, why don't we switch you over to an endurance based program to try to get you ready for the summertime activity. So, and having the ability to analyze your patient in terms of the patient's goals and what they're interested in getting back to, and then complementing that with our knowledge of how we can improve the body's baseline level of function, so they can then go out and do what they need to do and tolerate the demands of their activity without hopefully not exacerbating the condition that they're coming to see you for. And that's a common scenario that I run into in my clinic.
Hmm. You are a manuscript reviewer for the
Yeah,
Journal of Manual and Manipulative Therapy.
yes, that's correct.
In that role, have you come across any articles related to exercise that we should go check out or look at?
Not in my role as a reviewer, but I'm always keeping my eye open in the strength and conditioning world for articles that are coming out. One of the areas I think I've found a lot of interest in, and maybe what I'll do is I'll just kind of go over some of the NSCA model variable targets that they use for the training goals, and then I'll kind of segue into what the point that I was going to try to make. So the NSCA defines a strength training goal as 85% of the individual's 1 rep max. So that's the load. So the load assignment. The repetition range is 6 repetitions or less. And the set range is 2 to 6. And the rest time is 2 to 5 minutes. The power goal is 90% or more of the 1 rep max, and it's 1 to 2 repetitions, 3 to 5 sets, and again a 2 to 5 minute rest. The hypertrophy training goal is 67 to 85% of the 1 rep max, 6 to 12 reps, 3 to 6 sets, and 1 to 1.5 minutes rest. Endurance is less than or equal to 67% more than 12 repetitions, 2 to 3 sets, and less than a 30-second rest period. And when I started learning about this years ago, I was extremely fascinated with the rest time prescription. And my question was, well, why do you go 2 to 5 minutes on this? And endurance is less than 30 seconds. And it basically came down to energy utilization. And I may be making this more simplistic than it is. The way that it was described to me was that it was a reflection of ATP utilization in the Krebs cycle. And since ATP replenishment, breakdown and replenishment, which is where we get our energy, is time dependent, the influence of your rest periods in between your exercise sets can influence the amount of available ATP that you have to perform the next effort then after that. So with endurance training, endurance muscle behavior doesn't have ample supplies of ATP available to it. So that's why we try to train in a controlled setting. We try to train that individual in a similar way that their body is going to have or utilize energy utilization processes in their activities. If we're looking at strength, we're looking at how much weight can we move. We want to have as much of that energy available to us in between our efforts so that we can maximize each effort. So that's where the 2 to 5 minute rest time comes in. We want the body to recover as much as possible before we go ahead and do another effort at 85% or greater of our 1 repetition max. That breakdown that I just gave you is very generic, and I know there's people that will probably be listening to this that are more knowledgeable than I am, and they can probably shoot holes in those parameters that I gave based on some of the current research that's out there. But just in terms of a very generic and basic understanding of how to get more specific in exercise prescription, I think these parameters can be very useful to the clinician to help them start to design programs that are more specific to the desired outcome. One of the biggest areas of change in terms of the understanding of what happens at the muscle level is hypertrophy. So when you're looking at the research behind hypertrophy, the parameters that I gave are not really being used anymore. And we're finding that there's a wide variation of parameters that can be used to induce hypertrophy in the muscles. And Brad Schoenfeld is one of the leaders in hypertrophy world. He'd be somebody to definitely keep their eye out on. And I think going back to your original question, it was some articles to keep in mind, anything that's come out that would catch PT's attention that they might be interested in. Is that correct?
Yes.
Going off of those basic training goal parameters, anything that comes out in the strength and conditioning world is useful to look at. Some of the more recent articles I've been looking at are the usefulness of strength training in injury reduction. And there's 2 papers out that I would recommend by Laursen. One was in 2014 and the other in 2018. And I can certainly email that information to you after we're done here, and you could list that along with the podcast. Or they've actually looked at studies that used stretching, studies that used proprioception training, strength training, and then a multimodal approach, which would be incorporating proprioception, strength, and stretching as an intervention. And the results are interesting. They actually found that stretching has absolutely no correlation to injury prevention. So stretching for injury prevention is not supported in the literature. And the multimodal approach, which I thought would actually probably fare the best, actually did not fare the best. It was not the best way of exercising to prevent injury. Strength training by itself was the best chance of decreasing your risk of injury. Their explanation in the article was that when you have a multimodal approach, you have too many pieces of the pie in there, and you can't do necessarily one thing very well since you're doing 3 different things, and they were suggesting that that might be the reason why the multimodal approach did not pan out as well. But if you're looking at encouraging your patient in their resistance training program that you set up for them. The best opportunity for you not to end up in my office is to try and make yourself as strong as you can be, doing strength training even when you're done with your formal rehabilitation, because that's going to give you the best opportunity to try to avoid coming back to my office. So those two papers were interesting, and those are some of the more recent papers that I've read. I've had the opportunity to listen to Brad Schoenfeld speak in 2018, and I thought I had a basic understanding of what hypertrophy was and how to target that. After listening to him, I realized I actually didn't know anything about hypertrophy. So he's somebody that's been interesting to follow as well.
That's great. Thanks for all the information and the resources. We will post those in the show notes.
Sure.
I happen to have been researching for a lecture I'm writing and came across a recent article in the Journal of Physiotherapy
Hmm.
that was in that ilk of exercise programs may be effective for preventing new episodes of neck pain, a systematic review.
Uh,
So I can post that one in there too for folks to look at in relationship to prevention.
Yeah, and the NSCA just came out with a new textbook last year, I believe, and it's Strength and Conditioning for Special Populations. And I think it's a book that should probably be on every outpatient physical therapist's shelf. I have a patient that has Parkinson's disease, and I referenced that chapter from that book to help design my program for him.
Fantastic. Thank you so much. Sounds like your class you did was full of information and insight. Are you presenting at the 2019 conference?
No, this year I'm not going to be presenting. I Last year was my third year in a row for presenting, and so I decided to take this year off. Just go to the conference and listen.
Sounds like you deserve a year off. Well, thank you so much for joining us today. We look forward to seeing you at the conference and learning more about exercise prescription.
Yeah, thank you for having me, and giving me the opportunity to talk about this. I told a number of PTs that I think one of the more valuable interventions that we as physical therapists can use is exercise. And exercise was talked about quite a bit at the World Congress in Vancouver last week. And it's an intervention that has a lot of potential to it. And I think that we can be a more effective part of the solution to musculoskeletal health problems that are presenting themselves nowadays and will continue to present themselves as our population continues to grow. One of our slides that we had in our presentation was looking at the Medicare population in 2016, and it's going to be a huge population. So I think exercise is going to allow us, or exercise allows us to be effective in providing our patients with good information about what they can do to help themselves, how they can do it on their own, and the likely positive effects of that. And since I've been emphasizing this more in my practice, one of the things that I seem to be observing is that when patients see that they're not fragile, or patients see that they're not broken, and that they can actually lift some weight or push some weight, and it didn't exacerbate their symptoms, or if it did, the symptoms went quickly away. And when it seems to me, when the patient gets that realization that they're strong, they're not broken, even though they may have been told that by another healthcare provider. The common 30-year-old who has back pain gets an x-ray and their physician tells them they have the spine of an 80-year-old. When you're 30, you don't want to hear that type of thing, and that doesn't encourage a lot of confidence in your spine at that time. And when somebody like that can come into my clinic, and together we can work through this process of why it's safe to do something, again going back to that clinical reasoning process that I believe we as physical therapists have, as the patient and I work through that process of explaining to them why they might be having their symptoms and what they can do about it, and that it's okay to do these things. And then the patient starts going through that process and realizing that, and of course, the intervention being the exercise at that time. I think exercise it provides us with a very strong intervention, very specific to our skill set as physical therapists, that we can use to help our patients. So thank you for the opportunity to come on and talk about our presentation and the things that were important to us.
Oh, yeah, and I couldn't agree more. Exercise is where the body does changes. That's what stimulates the histological change, the adaptations, the increase in tissue tolerance, as well as the increase in strength. Manual therapy definitely has a role, in my opinion, or pain inhibition, in some cases biomechanical influence, but the real magic happens out in the gym when people get moving.
That's that's right. I agree.
Thanks so much.
Okay, thank you very much, Becca.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.